We're going to begin the next module with airway management, and it's its own module. It has all of its own skills. And this is probably one of the most important lessons that we're going to have throughout the entire course. So as we proceed through this, I want to talk to you about airway positioning, suctioning, adjuncts that we'll put in there, as well as how well somebody is oxygenating and ventilating. So if we look at all these things and we break them up into those categories, it doesn't seem to be as scary. I like this lesson because it's a lot of skills, but it's also a lot of numbers to remember. Numbers are very concrete. We say normal adult respiratory rate is 12 to 20 breaths per minute. Anything slower than that, we're concerned. Anything faster than that, we're concerned, but not if it's too much, not if it's not very much out of the norm, then we're okay with that. So we're going to look at all of these topics within here, determine the difference between respiration and ventilation. Those are two different things, and I'll explain those. I've added a few slides I think that will help tie everything together and make it all seem normal. Now, I do need to remind you that oxygen is a drug. You can't go to the store and say, hey, I'm here to get a bottle of oxygen, and somebody will bring it out to you. You have to have a medical prescription for that. So it's a U.S. pharmacopoeia medication. But a lot of this other stuff that we're going to practice is what we call basic life support. So could you just step out of your own vehicle, somebody not breathing, take care of them with no adjuncts whatsoever? Sure you could, if you're willing to do mouth-to-mouth ventilation. And I will tell you, let's probably reserve that for somebody that's very close to us that you know, and you're satisfied that that's what they need. We're going to look at airway and divide it into upper and lower, and I think that helps us with signs and symptoms and management of this. So two of the most important life-saving skills that we're going to do are airway care and rescue breathing. For the people who need it, not for the people who don't. So even though we do a CAB approach, we look at, do they have any signs of circulation? Are they moving? Are they moaning? Are they attempting to move their chest to breathe? And we check a pulse, so we jump right into circulation so we can see if somebody's not appearing to be awake, that we check that first so we can get on the chest and start compressions faster, just like we didn't learn in CPR. But when we look at airway, we still think about airway breathing circulation, meaning that I don't progress to the next step until I take care of the step before that. So if somebody's got an obstructed airway and they're not moving any air because they choked on a peanut or they swallowed a hot dog or whatever, I can't start ventilating for them. I can't do anything until I clear that airway. So it's a hierarchy of care. When we look at anatomy and physiology, so the function of it, we have to have a constant supply of food, water, and oxygen in our bodies. So you can say, well, I can go for 6 hours without food. Yeah, but we have residual sugar stores that allow us to do that. I can go all day without a drink. My mouth is dry, but I have residual water supply, and then my body starts shutting down and says, fine, if you're not going to give us any fluids, then we just won't pee anymore. And then oxygen. Now, oxygen of those three is the one that we can't even survive a few minutes without. After about 4 to 6 minutes, brain cells begin to die. After about 10 minutes, those irreversible brain death, as well as the heart. So oxygen is vital all the time. Oxygen requires that we have an intact nervous system to create the negative pressure for our ventilations, for our breathing, as well as a heart to pump that oxygen around to all parts of the body, and lungs to exchange the oxygen that's coming into the body for carbon dioxide. Now here's kind of a neat little fact. At sea level, we're about 20-21% oxygen. The higher altitude you go, a little bit thinner, and it doesn't take a whole lot. So let's just round that to 20. Let's make it easy. When I breathe in 20% oxygen from the atmosphere, and I breathe in about 0.4% carbon dioxide. But when I breathe out, I brought in the oxygen that my body's going to use, and I'm blowing off a waste product called carbon dioxide. It contains about 16% oxygen and about 4% carbon dioxide. These are fun facts. Don't worry about memorizing them. But the thing here to grasp is that if I breathe for somebody else with my own lungs, I'm only giving them about 16% oxygen. So when you make that decision, I'm going to do mouth-to-mouth, I'm going to expose myself to somebody else's bodily fluids, as well as their airborne transmission of whatever they might have, I'm only going to give them 16% oxygen. Now, if I want to blow on anything, blow on your plants, because plants need carbon dioxide, and now you're blowing off 4% carbon dioxide for them. So looking at the anatomy and function of the respiratory system, let's divide it right here at the larynx. This little line right here is the voice box. And in the voice box is a little flap of skin right here north of it, superior to it, called the epiglottis. And what that epiglottis does is it directs which way, which tube, whatever is coming in the mouth is going to go. So when you take air in through the mouth, the epiglottis will open and allow air in to the trachea, to that windpipe, so it can travel down the lungs. When I swallow, it closes it off, so whatever I've swallowed, fluid or food, will pass down through the esophagus, which lies just behind or posterior to the trachea. So sometimes we take a little sip of something and it chokes us. We've got a very sensitive gag reflex, and that's because it's protecting the trachea and the lungs from anything going down there. So you take a little sip of something and it starts to go down the wrong way. That epiglottis mostly closes. It still lets some air in. Mostly closes, and the larynx spasms to protect you. So you're coughing, not very forcefully, and then somebody comes up to you and say, hey, are you all right? And you go, yeah, I'm okay. That's because of that laryngospasm to protect the lungs from anything that should go down there. So let's start right there in the middle, and let's go up here at the north. So we've got the mouth, that's an oral pharynx, and we've got the nose, that's a nasal pharynx. If you don't believe me that they're connected, drink something. I don't care what you drink. Drink a soda, and or have somebody else do it and tell them a real funny joke and watch it blow out their nose. Yeah, so the oral pharynx and the nasal pharynx are connected back there toward the sinus cavity. So not a very fun thing to do if you have milk, though. It'll actually kind of sour up in there and not smell good after a while. And probably not a good thing to do to anybody. But at any rate, back here at the back of the throat, we call that then the hypopharynx. And that's about where the tongue lies at the back of the throat. I'll show you some pictures where the tongue's involved in your airway in just a little bit. So then moving to the lower airway, right there past the larynx, we've got a 15-centimeter trachea, and it divides into the right bronchus and then the left bronchus, and then these little passageways are called bronchioles. And the whole thing is to go down to the lowest passageway, which are the alveoli. Alveoli are tiny air sacs with blood vessels around them. We'll talk a little bit about blood vessels when we get into cardiac, but capillaries are thin-walled vessels where gas exchange can take place because they're so thin. I kind of think of them like Swiss cheese, where molecules move in and out from them. So this is where we take a deep breath, and those alveoli fill with oxygen, and then the bloodstream comes by, picks up the oxygen, drops off the carbon dioxide, and then when I exhale, I get rid of the carbon dioxide. So there's a lot of mechanics in how this works. This dome-shaped muscle down here is called the diaphragm. When it relaxes, it moves upward, making the space in the lungs smaller. And when we take a deep breath, it will contract or move downward, as well as the muscles in between the ribs here, the intercostal muscles, moving the chest forward, backward, sideways, upward a little bit, and also downward. It makes that space very big. So you think of it like an accordion. When you pull an accordion out, air gets sucked into the accordion, and that's what we're doing when we breathe. Breathing in is active process. It requires energy, whereas take a deep breath now, and then blow it out. When you blew it out, all you did was relax. Inhalation then is active, excuse me, and exhalation then is very passive. So in an unconscious person, maybe they're still breathing, but they're no longer able to protect their own airway. And so that's why you really have to watch those people that become unresponsive. And the biggest thing that blocks that is the tongue. If any of you snore, or partially snore, or whatever, it's just your tongue partially blocking that airway at night. And it's positional. You lay flat on your back, it's going to be worse than if you laid on your side or on your stomach. Not always. But the tongue's attached to the lower jaw, so that produces that snoring sound. In your patient, you cannot just say, oh, he's snoring. No, we're going to fix that by positioning the airway or inserting an adjunct. And here's a picture of the tongue occluding. This is almost a complete obstruction on the left side, very little air passing through, and then this is an open airway. So people can actually become so deeply unresponsive that their tongue completely occludes the airway, and they don't move air anymore until their brain starts losing brain cells. So not a good thing. And this is what we talked about, the two passageways, the esophagus, which is a tube that goes from your mouth to your stomach, taking food and fluids, and the trachea, which takes air to the lungs. So that epiglottis, that leaf-shaped flap, is so vital in preventing food and water from going down to the trachea. The trachea divides into the right and left bronchus. Right bronchus, left bronchus together, they're called bronchi, and then travels down into the lungs. Those smaller passageways are called bronchioles, and then the tiny air sacs are called alveoli. Boy, do you have to remember all that? Be familiar that they're in the lungs, and the more that you understand of this, the easier it is to retain. If you just memorize things, then, our memory fails, but if you have a true understanding, it makes it easier. And that exchange of oxygen for carbon dioxide is called respiration. Respiration. We're actually moving oxygen in and removing carbon dioxide. And here kind of is a process. You can pause the video and just kind of stare at this for a little bit. But the red is oxygenated blood, and the blue is blood that's low in oxygen, deoxygenated blood. Think of the lungs as a sponge, not an airbag, not a balloon. So they're soft and spongy. Air moves in, but also circulation and also some tissue that's there. So it's not just like a big balloon going inflating and deflating. One thing I will tell you, though, is quite interesting. So do you think a paper bag will bust easier if it's full or if it's like half full or half empty, depending on if you're a pessimist or an optimist? Well, yeah, it would burst easier if it's full. So think about this. When somebody is going to be in a car accident, they see it coming. Somebody's coming straight into them. They're almost going to hit a tree or whatever. The natural tendency is to brace for impact. So if we're driving, we'll hang onto that steering wheel real tight. We'll take a big, deep breath, and then we hold our breath. So no wonder people get pneumothoraxes, get collapsed lungs when they're in wrecks. So I have some good advice for you. If you ever see that you're going to be in an accident, you're going to hit something that's unavoidable, instead of inhaling and holding your breath, you should scream. Because then that's going to let a lot of the air out, and it's going to make it harder for it to collapse. Also, because we wear seatbelts all the time now, if you have a full bladder, that bladder can rupture from that seatbelt. So at the same time you're screaming, you should also wet your pants. Then, if you avoid the accident, worst case, you wet your pants, but you don't have a ruptured bladder from that. And that's good advice. Here it shows on the left, inhalation, the diaphragm contracts down, and the intercostal muscles, those between the ribs, expand out, making that cavity bigger, and it draws air in. We don't really sniff air in, we just make the container bigger, dropping that atmospheric pressure. It makes it lower, so air flows in. Whereas when the diaphragm relaxes, it's a passive process, and the air moves out. This is a good stopping place. Keep this nice and short, and we'll call this part 1.